Hello, this is Dr. Taylor, and the next lecture here we're going to introduce you to is the stress connection. After I had been learning and lecturing about bioidentical hormones, primarily female hormones, estrogen and progesterone, I met someone who heard me speak and was excited that an OBGYN was talking about bioidentical hormones. This was back in the early 2000s. And he said, if you really want to help patients, you need to understand stress, cortisol, and thyroid. And he said, if you understand that, you'll really be able to help people. And so I took it upon myself to learn about this, and he was exactly right. It's going to be very hard for you to balance hormones and get the best result from understanding bioidentical hormones with women and men if you really don't understand the stress connection. And so we're going to talk about the stress connection, connecting the link between stress, hormone dysfunction, and immune suppression. You know, about that time, I started having some patients who I'd been seeing for a couple of years, and initially, when we gave them progesterone, primarily some estrogen and progesterone, you know, they were thinking it was the best thing since sliced bread. That's kind of how I was with my wife also, thinking it's the, you know, this is just great. But then patients started to come back and saying, you know, doctor, I'm still having some fatigue, and I still get this nervousness and irritability. It's not as bad as it was with the PMS and before the progesterone, but I still have it. And then I have some depression that still comes upon me. I'm not concentrating as well. You know, I'm more apprehensive. I don't take as many chances. I'm not as bold as I used to be. You know, I'm feeling a little muscle weakness. You know, I'm just getting frustrated. I'm kind of getting overwhelmed. I have some cravings, and you know, it seems that sometimes when I stand up, I get some vertigo, and it's like, oh, I'm like, well, is that all? And she says, no, I have some lightheadedness, and you know, I still have some trouble with insomnia, and my PMS still comes every once in a while. You know, I have these headaches. You know, I'm having these muscle pains and spasms and epigastric pain. Do you think I need some Prilosec or something like that? You know, I think I may have GERD, or I think I've heard this on commercials on TV. And then I think I have some food allergies, and then I have some indigestion and, you know, diarrhea and constipation. Do you think I have irritable bowel? You know, my sister has irritable bowel. I have some friends who have irritable bowel. Do you think I have irritable bowel? Oh gosh, and you know, you say, wow, this is one of these patients coming in with all of these, you know, all of these vague symptoms. So, you know, what am I going to do? Well, even though we've learned, you know, other things to do, a lot of times when we get into those situations, you just fall back on what you know and what you've been used to doing. So you draw FSH, a serum thyroid, a CBC, a SMA7, a cholesterol, ANA, and all those dots is that you can mark everything on the Quest or LabCorp lab sheet. You just order everything because she's complaining of everything under the sun. But even though you fill that lab request form out, marking all of those, you pretty much know that they're going to all come back normal. So now, Miss Jones, she's going to come back to you in 2 weeks. You know, she said, you know, you've drawn enough blood on me to fill a swimming pool. You have got to have found something there. And you look at the lab report and you're like envious of her lab report because it looks better than your labs. And so you have to walk in there and tell her, you know, Miss Jones, I know you're having some problems, but we really didn't find anything. And so Miss Jones says, you know, well, what about my fatigue and irritability and depression and inability and headaches and muscle pains and so? Well, what about all of that, doc? Well, then you say, okay, Miss Jones, here's what we're going to do. We're going to order an ultrasound, a CT scan, upper GI, endoscope, laparoscope, so on and so on. And you order all those things. And really deep down in your heart, you know that all of those are going to come back normal. But one thing you did do is two things you did do. You were able to get out of that room and keep Miss Jones from continuing complaining to you. And where the lab tests, you told her to follow up in 2 weeks, you know it's going to be at least 6 to 8 weeks before she could get all of those scans and everything scheduled. So at least you didn't have to see Miss Jones for another 6 weeks. So you did accomplish something. But Miss Jones, she never misses an appointment. She gets there early. So she comes in, you've got all of these reports from her ultrasound, CT scan, upper GI, and endoscope and laparoscopes, and every last one of them says no abnormality found. So you walk back in there to see Miss Jones, and you say, Miss Jones, you know, we really didn't find anything. We really don't know what's going on with you. And she says, well, what about my fatigue, my nervousness, my irritable, my PMS, my diarrhea, constipation? Do you need, I think I need Prilosec? Do you think I have irritable bowel? What's going on? So you say, okay, Miss Jones, Miss Jones, Miss Jones. Then what you have to do is pull out the big guns. You have to practice visitus interruptus. So you pull out your prescription pad because she's not going to be happy until you write her a prescription. Now, these are the top 10 prescriptions. You see there's Synthroid, there's lipid medication, there's immune system medications, there's medications for the GI, there's insulin resistance, neurologic. Now, the problem is a lot of these are given without a clear-cut diagnosis, but these are the top 10 prescription drugs. So it's popular to give the popular drugs. That's what everybody's given, but those are mostly for symptom relief, not necessarily for a diagnosis of a particular condition. And the problem with popular thinking is that it doesn't require you to think at all. It's easier to do what other people do and hope that they thought it out. Because all of these drugs, it's very hard to say that there's a, except for the insulin resistance, it's very hard to say that there's a diagnosable disease when you're talking about restless leg. You're talking about, you know, these allergies and the Nexium for the GI symptoms. Is really not treating a particular problem. It's really trying to get rid of symptoms. So even though we don't have a clear-cut diagnostic criteria for a lot of these, we have come up with some popular non-diagnoses. A lot of people walk around saying they have chronic fatigue. Now, how do you diagnose chronic fatigue? After you do a CBC and they don't have anemia, what else do we have? Well, the way you diagnose chronic fatigue is like this. A patient has to come in and say, doctor, I am tired all of the time. And you tell her you have chronic fatigue. Now, what did you just do? What you did was you just rephrased what she told you. He or she told you. She said she's tired all the time. You said she has chronic fatigue. What does chronic mean? It means all the time. What does fatigue mean? It means tired. So she tells you, I'm tired all the time. You tell her she has chronic fatigue. You just regurgitated what she said. You really didn't give this person a diagnosis. Patient comes in for fibromyalgia. You diagnose fibromyalgia. Well, how do you diagnose fibromyalgia? There's really no clear test for it. But the patient has to come in and say, doctor, every muscle and joint in my body hurts. What does fibro mean? It means connective tissue, what joints are made of. The my in fibromyalgia is for muscle, and the algia is for pain. So the patient says she has pain in her joints and muscles all the time, and you tell her she has pain in her joints and muscles all the time. Fibro, joints, my, muscle, algia, pain. Patient says she's depressed. You add an ION to it and say she says she has depression. Patient says, I can't concentrate. You tell her she has a deficit in her attention. That's what I can't concentrate means. Patient says, my bowel is irritated. Everything seems to irritate my bowel. You say she has irritable bowel. Patient says, my emotions are up and down. I'm anxious and depressed. I'm happy when I shouldn't be happy. So you say you're bipolar. You're at both ends of the spectrum. So there's so many people with these diagnoses, which really aren't diagnoses. They're really just descriptions of their symptoms. And the pharmaceutical industry has taken hold of this, and they have made drugs to fit symptoms and not necessarily to treat whatever is causing all of these problems. Now, we can relate all of this to stress, and that's what this lecture is going to be about. How can stress be involved in all of those symptoms? And if you diagnose and treat stress, you will actually get to the core of these problems. Now, stress is involved in this, and if you think about stress, you will be right most of the time. The economic impact of stress. The disability caused by stress is just as great as a disability caused by workplace accidents or other common medical conditions such as hypertension, diabetes, and arthritis. We present evidence that calls for early recognition of workplace stress and for businesses to allocate more resources to stress management in the workplace. So this is a study done in the Journal of Metabolism in 2002. And it says that the impact of stress, 43% of all adults suffer stress-related adverse health effects. So almost half of the population has adverse health effects that originate from stress. 75 to 90% of all visits to primary care physicians are for stress-related complaints or disorders. So let's just stop right there. 75 to 90% of everyone who visits your office, if you're a primary care physician, is for a stress-related complaint or disorder. Now, if 75 to 90% of your patients had diabetes, would you not want to know everything you could about diabetes? Wouldn't you go to diabetic conferences? Wouldn't you join the Diabetic Association? Wouldn't you read diabetic journals? You would want to know how to treat 75 to 90% of your patients. If 75 to 90% of your patients had cardiovascular disease or hypertension, you'd want to know about hypertension. You want to know all you could know about hypertension. So if 75 to 90% of all visits to primary care physicians are for stress-related complaints and disorders, you need to know everything you can about stress. And that's why I devote so much time to this, because if you think that stress has something to do with your patient's adverse health effects, you're going to be right 75 to 90% of the time. And I don't know anything in medicine where you're right that often. So we really need to understand how to diagnose and treat stress and stress-related disorders. Stress has been linked to all the leading causes of death: cardiovascular disease, cancer, lung ailments, accidents, cirrhosis, and suicide. An estimated 1 million workers are absent each day with stress-related complaints. So this is affecting our gross national product. This is affecting the productivity of our workers. Stress is responsible for more than 25 billion workdays lost annually because of absenteeism. So if we can get a hold of this, we'd be better physicians, we'd be a better country. So I really think that this is probably one of the most important concepts that I've ever learned. And I think this is something that I want you to understand also.